Hello, everyone. My name is Nick Goodwin. I'm here with my good friend Jeremiah Johnson, fellow psych nurse, fellow SEC instructor, and we're going to talk about maybe a little bit about therapeutic communication, maybe a little bit about personality disorders, hopefully a lot of it about Jeremiah Johnson.
Yeah, we'll see.
Just a lot about Jeremiah. Do you want to? I think it'd be cool to get some background on Jeremiah Johnson. Do you mind talking about maybe what got you to being a psych nurse? What that road was like?
Sure. So I guess just a little bit about me. Married, got 2 kids, whole fun there. And then, so I was in the military. I went to Iraq for a year. Got back from there, started going to school, went to SEC, got my AA degree, and then transferred at that point to Gonzaga, and got my bachelor's at Gonzaga, and since then I've been working pretty much in psych the whole time. Started working out at Eastern State Hospital.
Was that like a deliberate, like, I'm going to get into psych, this feels right for me, or did it just happen to be the job you get, or how did that work out?
A couple things. So, first off, I realized I wasn't a med-surg fan. Just the whole idea of task after task after task. Totally, I get that some people love it, and it's totally the field they need to go into.
Super essential field to help people in.
Gosh, yes.
We need our med-surg nurses.
It just wasn't what I was drawn to. Had a couple of psych rotations with over at Gonzaga, one of them over at Eastern State Hospital, and then prior to that it was what is it? It's that
was it one of those
substance abuse place for young people?
Oh, was it Daybreak?
Daybreak, yeah.
Oh, right.
I was over at Daybreak, and actually that one is the one that first got me interested in psych. Talking with some of the social workers and what they deal with over there, just kind of got me interested in the fact that they really are trying to help a lot of young people over there, and so it just got me interested in that. And then of course Eastern State Hospital, and then worked there with this guy.
Yeah.
I'm currently at work over at the VA on the inpatient psych floor.
The difference between like Daybreak or even an inpatient treatment, substance treatment center versus an inpatient psychiatric unit is almost like it was probably deceiving maybe a little bit, because Daybreak is so interactive with their patients and so like not like, hey, stop yelling and screaming, more so like, hey, let's actually talk about some therapy and implement some ideas that might help you, instead of just to keep you sort of safe for a couple of weeks or months before you discharge.
Yeah, and I think they were doing the CBT there, where they were doing a lot of mindfulness exercises and a lot of just centering themselves, and so it was a lot more interactive. Yes.
Yeah, a lot more interactive than telling people not to hit each other. One big piece that I think is hard to teach, I have a hard time teaching, is therapeutic communication, because there's a lot of theories to it. I don't remember feeling like I had it. I remember one time I was first started my job as a psych nurse, and I was in orientation, and I was sitting at the nurse's station, and a woman came up to the nurse's station and just started yelling at everyone, and just yelling full throttle. I don't remember about what, the phones, cigarettes, usually common themes, but I remember thinking to myself, if I had to deal with her, which I'm going to have to in 2 weeks, I have no idea what I would say to her. I do not know what I would do just to get her to be happy or to calm down. And I think I'm pretty good at therapeutic communication now, but it's been such a do it 100 times and you start realizing you're pretty good at it. Mm-hmm. But I know a couple of tricks for therapeutic communication that it would have been, I think it's good to know. So you have sort of maybe a tool, maybe an algorithm or something to come into a situation, and someone tells you something that you've never heard in your life that's absolutely ridiculous or horrifying or profane or anything that's going to throw you off, and you actually can say something and not just sit there frozen as you're just like, why is this person yelling at me, and how do you get them to stop? So, but you teach mental health first aid, which I think is a super cool I don't know, just a cool concept. Do you mind talking about that a little bit, and then also maybe talking about your approach to how you interact with people who are very challenging to interact with?
Yeah. So mental health first aid is a course. It was initially developed over in Australia, and then it's spread to just
Yeah.
well, I think it's in the hundreds now, different countries and everything that use it. And basically, it's an idea of you go to if you have issues with cardiac, and you're gonna have a cardiac issue,
Yeah.
you're gonna go down. Seattle's a great place to be because, like, I think it's like 70 to 80% of the people there have gone through CPR classes just
Oh, wow.
on their own.
Yeah.
Whereas, and then first aid courses are out there, and
Yeah.
what mental health first aid is about is sort of the same idea. So, teaching people how to, and a lot of it is just how to communicate with people
Yeah.
who may be experiencing some sort of mental health crisis. Now, understand mental health crisis, we're talking depression, anxiety. A lot of times we tend to think just the the schizophrenia, somebody's
Right.
acting psychotic, or
Yeah.
the bipolar, but
Yeah.
also understand that depression and anxiety and people who are having suicidal thoughts
Yeah.
are also a mental health crisis.
I think it's, in society right now, there's a lot of attention on being able to identify somebody in a depressive or suicidal crisis, and people have sort of taken on this burden without having an idea how to do it.
Right.
So that's a huge thing. I'm glad you acknowledge that also means someone in that case. Yeah.
Yep, and we practice. First off, a lot of what it deals with is stigmas,
Yeah.
and what we may think about what suicide is, what we
Yeah.
may think about different mental health issues, and it deals with stigma, but then it also kind of deals with, okay, well, how do we just approach it, and how do we talk about it?
Yeah.
I remember, probably when we first started out at Eastern, one of the most difficult things to ask is, are you feeling suicidal?
Yeah.
For me,
Absolutely.
at least, it was.
No. Yeah. Absolutely.
And because it just seems like this.
It feels intrusive.
Yeah.
And it's still, even though we know that's not true, but it feels like you could give them the idea.
Right.
It doesn't, even though the science says you can't, you still feel like, but what if they weren't and then they become it? Like, what if they're like, well, actually, I haven't thought about that. Maybe I will.
I'm really depressed.
Yeah,
but
I am depressed. Maybe suicide. That doesn't happen. It doesn't work that way.
No.
So, but it is. It's a weird thing to say to somebody.
Yeah. And what's so funny is we as nurses, I mean, we sit there and go, oh, when was the last time you pooped? And
Yeah.
No
Right.
big deal.
No big deal.
And yet when we go, hey, when's the last,
Yeah.
have you had any serious thoughts of
Yeah.
wanting to harm yourself or
Yeah.
or to suicide?
Yeah.
It just becomes this huge thing in our minds.
Yeah.
Just this huge thing to overcome. For some people, it's not. I've found that even working with SEC students, some are just like, oh, let's just dive right in and do
Yeah.
this.
I've been super impressed with that too. Yeah, they're just like, they're ready to talk about it. They're very passionate. So, what are some techniques? Maybe what are when you have somebody who you have to have a really challenging conversation with, maybe because they have psychosis, maybe because they're just angry, maybe because they're going to tell you about how they're suicidal. What approaches do you take?
Well, there's kind of a lot of things to think about. So, a couple things to think about. First off, first thing I like to figure out is,
Yeah.
am I the best person to talk with
Yeah,
this
that's
person?
real. Yeah.
Sometimes especially when we start looking at when you're working on a med surg floor,
Mhm.
you're the nurse for
Yeah.
a particular set of people, and oftentimes you don't want to be the nurse who says, oh, chest tubes, gosh, Bill's
Yeah.
better at this than I am.
Right.
You don't want to do that, right?
Yeah.
So
a nurse is a nurse. You should be able to have that
you should
conversation.
be able to do that, right?
Yeah.
But when it comes to psych,
Yeah.
let's just face it, when you connect with certain people,
Yeah.
some people you easily get along with, other
Yeah.
people it is just a chore.
Yep.
As a nurse, it's really important to know, am I the best person to talk with this person?
Yeah. Do you have that rapport built?
Do I have this rapport? Or maybe it is Bill
Yeah.
who has the rapport.
Yeah. What are we
And-
trying to tell them? Are we going to tell them something that's really upsetting to them? And do we just not know each other? Do we rub
Right.
each other wrong? A lot of times I would ask that, who has rapport with this patient? that never really meant a good thing, but somebody usually would say, this person does, and I'd ask them to do it. Or ask them to whatever, pass along the message, or tell them, hey, you should take a shower, or...
Right.
I remember there was a patient that you had really good rapport with, and she was a very challenging patient. Do you know what I'm talking about?
I think so.
Okay. One story.
Snake bites.
Yeah, snake bites. Yeah. She really liked you. And one time she asked us for the Bible. She asked us to check out the Bible, and she came up to you and she had ripped out the book of Jeremiah for you, which is the nicest thing I imagine she has ever done for anybody. She's just has a series of just terrible things that she tends to do to people, but for you, she gave you the book of Jeremiah.
Yeah, and I was asked to talk with her a bit sometimes.
Did you? I bet you did, yeah. Where's Jeremiah?
Hey, why don't you talk with her a little bit? Alright.
I remember one time she had made a suicidal statement, and so we put her on a 1-to-1. I think it was a friend of ours, Amelia, who was with us, and we made that decision, and she sat on her. And when she was done sitting on her for an hour, she said, we had to take her off that 1-to-1. Because it's just the profoundly upsetting things that this patient would say for an hour, to have to sit here and listen to those profoundly upsetting things. It just wasn't worth it. It wasn't worth it. And she wasn't. I mean, you after you talked to her, she was like, "No, I just said that because I was angry." But
Right. To go off something else, the other thing that it took me a long, for whatever reason, it took me time to figure out. Talking with people like they're people is, in my opinion, the number one thing.
Yes.
So once you've figured out who it is that's good at talking with this person, the next thing is just going. It's just another person, and they're in some sort of moment of extreme panic, extreme fear, extreme anger, which a lot of times anger is just built out of fear.
Yep.
And they're just experiencing a real human emotion.
Yep.
That we have all experienced.
From our experience.
And they're afraid, scared, and angry about it.
Yeah.
And just talking with them like they're a real person is amazing, because for a lot of these people's lives, they're not talked to like a real person.
Yeah,
because of the stigma that goes around mental illnesses. And just talk.
Yeah, especially in stigmatizing environments like an inpatient psych setting or an inpatient treatment center, or if they get stigmatized as the mental health patient on a med surg floor, whatever. Like they know it, even if they're not oriented to reality, even if they're pretty sick at the moment, they understand it, and they recognize right away if you come up to them as just a fellow person. You say, "Hey, how's it going?" We're just like I usually I'll say hello to my patients like I say hello to my parents, like I say hello to my what I mean. You just speak to them the same way in the manner, and they really you can see that rapport build right away, because they open up, they brighten up a little bit, because you're talking to them in a normal way, and to normalize anything in those environments is very helpful, because it feels like it's scary, and it's like they feel like they're in a cage. I mean, they feel like they're in under a microscope with the psychiatrists, and they're in like they're being observed. Yeah. And it's just it's such an unusual environment. So to give them any piece of normalization, it does wonders at building rapport. And you see people who don't take that approach, and how much less rapport they're able to build when it's when it's not normalizing, when it's not conversational, when it's, oh, you're the patient, I'm the provider, and we're gonna have this exchange, and then they feel like they're a patient. They feel like they're a mental health patient. That's cool. Good insights. You wanna transition to personality disorders?
Sure, let's go.
Let's do it. Personality disorders. I really. So I will talk about it. I don't like to talk about that. I'll talk about it. So I have a printout of all the personality disorders. I really don't feel like I've seen these. There's 10 of them, and they're in different clusters. And I've seen antisocial personality disorder a lot. I've seen borderline personality disorder a lot. And I might have seen the rest. The personality disorder is just not a clean box to put somebody in. Right. And so that's why it's often a cruel box to put somebody in, because between people it means very different things.
Right.
And usually you don't see somebody with actually I've never seen someone with just schizotypal or schizoid personality disorder. It's amongst things.
Right.
It's kind of blurry. And actually a lot of times you see people with the cluster B or antisocial borderline personality disorders, really a lot of times it's hard to decide which one's which, because they're very mixed. So we have the 3 clusters: cluster A, cluster B, cluster C. Do you have any insights as to why they're separated that way?
Well, cluster A's tend to be more of the isolative, sort of fanciful thinking or odd behavior or odd thinking.
And you were talking about that earlier, where so there's paranoid, schizoid, and schizotypal, and they're isolative, right? There's reasons that they tend to be away from people, from society, but for different reasons, right?
Right. So paranoid tends to be because obviously fears.
Yeah.
Fears that people are against them in some way.
Yeah, coming after them or...
Yeah, and it doesn't have to be like they're like I'm gonna try and kill you, but
Right.
just everybody's against me
I
and
gotcha.
getting a job.
I
Everybody's
see.
against me, and so it doesn't necessarily have to be like threatening their life, but it can be just threatening to them as a person in some level.
There's a big differentiation between these personality disorders and then you go on to like full-blown psychotic disorders. Is there's a ton of, they're like a step back maybe, they're a little more subtle. So like having paranoia that someone's going to come and kill me or someone's watching you or tapping your, that's a pretty severe form of psychosis, and I wouldn't be interested in your personality disorder. I would then start saying, what sort of psychotic disorder do you have?
Right.
So when you're thinking of paranoia, you're thinking of more of a subtle...
Well, and the other thing is with that, and the other thing is with if it's something that's more due to psychosis,
Yeah.
If you get them off the drug or if you get them on a certain medication,
Gotcha.
generally that'll go away.
Yeah.
With a personality disorder that's dealing with paranoia,
Yeah.
you could give them all sorts of medications and it's going to remain.
Yeah.
Because personality disorders have been developed over years and years
Right.
and years.
It's more of a developmental thing rather than neurochemical imbalance.
Exactly.
So if there's no neurochemical imbalance, you can't fix it with antipsychotics.
Right.
So that makes a lot of sense. So the paranoia, they isolate it because the people are against them.
Right.
And so then you have schizoid.
And they're just isolative because they don't want to make relationships
That's
with
right.
people.
They
So
don't
they
want-
just want to stay away from other people
Yeah.
and just be by themselves. And they actually end up having a very intense, like, just sort of life inside of their
Okay.
head, this sort of fantasy
Yeah.
life that they have within their head because they just kind of stay away from everybody. And it's not necessarily because they're afraid of anything
Right.
or because they have, in schizotypal, they kind of are isolated because their odd behavior
Yeah.
kind of sets them apart.
Right.
When schizoid, it's just, I don't want to be around you,
Yeah.
so...
I have no interest in social interactions at all.
Right.
Like a complete lack of interest. Part of me always the sort of cynical is like, then why do we have this clinical profile of this person? Because they're not going to come to the doctor's office. And I think I have somebody that I know that's like this, and it's in a weird way ironic because this person will I think he's a very conservative American mountain person who believes in really traditional values and stuff like that, but he would use like these natural herbal remedies. You know what I mean? Like
Right.
it seems it actually makes sense going together, but in sort of our political system feels at odds with each other
Right.
because he's looking for these ways to not have to go to the doctor.
Right.
Because he doesn't want to go to the doctor. Because honestly, he wouldn't trust the doctor if he went.
Right.
He wouldn't believe them.
Right.
And so, in order for him to actually get treatment, he has to kind of figure out these ways that he can do it himself. But they really avoid it. So
Right.
you'll more likely see this person with like a severe medical issue that had to come in.
Right.
And then that's my way we see this.
And oftentimes you're not going to see, like in the cluster A group, I have seen I've seen a schizoid and I've seen a schizotypal.
Yeah, but like one
But
each.
one, out of the four, I don't know, it's been a long
Like 6.5 years you've been a nurse, right?
Yeah,
7
it's
years?
been 6-7 years now.
Yeah.
Yeah, so seen maybe one of each of
Yeah,
those.
and I remember coming to teach this last year and saying, I don't know how to teach this. The DSM-5 has the criteria, and I remember just opening up the DSM-5 and just reading out of it because I just didn't know, and I know that this is on NCLEX,
Right.
so which is kind of goofy, but it exists and people have this and
And you just don't see it.
I don't see it. And so schizotypal is they have the weird magical thinking, so you will see them around. It's not like a psychosis that could get them detained, probably, or get them hospitalized.
Right.
It's sort of an odd thinking, and it can be very difficult for them to have social interaction.
And they actually can have visual disturbances.
Okay.
Usually the visual disturbances are sort of peripheral,
Okay.
from what I understand, and
Yeah.
it's a lot of times like shadows or like the little lights,
Yeah.
like little lights that just kind of ping off in the peripheral
Okay, interesting.
vision. And but oftentimes, as far as it's just a lot of just odd
Yeah.
behavior, odd thinking.
Yeah.
And again, it's one of those things like you give medication, it's not going to go away.
It's not going to help them with it.
Right. So you give them all these, risperidol and Zyprexa and all this other stuff, and they're still going to have the visual distortions. And
We had a patient who was detained because he just really scared his community, but he was kind of like, I think he might have probably had a degree of this. Like I said, it's never fluid, it's never concrete, but he would walk around with 2 giant walking sticks, and his mantra was, speak quietly, carrying 2 sticks.
instead of a big stick, right?
Yeah, instead of a big stick, it
right.
was 2
Well,
sticks.
2's better than 1.
2's better than 1. So he would go into grocery stores with his 2 sticks, and he came across as very threatening, partially because he would make threats, veiled threats usually, but he would say, if you don't, if he'd get protective of her female patients, and to get to a hyper vigilant extent, and so he'd come to us and say, you can't do that, or else, or something like that. It was very threatening, but he didn't think it was threatening. And so he'd go around the grocery store with his 2 sticks, and he'd get himself kicked out of grocery stores, and then eventually got himself detained because people were just afraid of him.
Right.
But he, ultimately he didn't mind necessarily that social rejection, other than he probably wasn't super aware of it.
Right.
He didn't have the insight into
And
it.
that's kind of the thing with schizotypals. Yeah, they tend to get a bit
Yeah.
isolated, but it's more society that isolates
Yeah.
them versus their intentional isolation
Right.
of themselves.
Yeah, and they just couldn't understand his way of going about things, and that he probably wasn't going to hurt anybody. All right, let's do cluster B, because that's the fun one.
Yeah, that's the one that just about if you work psych, you know cluster. Well, even if you don't work psych, you end up.
Oh, yeah, you're gonna see them all the
cluster
time.
B, yeah.
And I really think antisocial personality disorder, borderline personality disorder is important too, but I think antisocial personality disorder is really important for all nurses to be super attuned to, because you're going to see them in every environment, and they can really be on a range of dangerousness. And I think for somebody who's not used to or doesn't understand this disorder, can be easily manipulated, if not even preyed upon, because they don't come across as you think they would. Do you want to speak to kind of your experience with antisocial personality disorder?
Yeah. First off, so kind of the difference with cluster Bs
Okay, yeah.
is it tends to be manipulative.
Yeah.
Like all 4 of them tend to be manipulative.
Mm-hmm.
And then also can be dramatic.
Yeah.
So yeah, antisocial, it tends to, the manipulation and dramatic part of it is them getting what they want.
Yeah.
So at any cost,
Any cost, yeah.
any cost, and so they can come across as the sweetest of
Yep.
people because
Very conversational at times.
Oh, just because they want to, it's just furthering their goal.
Yeah.
So whatever it takes
Yeah.
to further their goal, that's what they're gonna. And in fact, they talk about how in like if you look at finance
Yeah.
in New York,
Okay.
a lot of the guys who are doing the trade
Sure, I imagine,
who are
yeah.
calling, a lot of antisocial personality
Because the
disorders.
dichotomy there is that they're very nice, very friendly, very personable at times, right? Sometimes some people just aren't, but usually they all have a degree of that charmingness there. And then in the other sense, they have no empathy,
Right.
complete lack of empathy, and sometimes they really want to cause harm.
Right.
I think at least they have no empathy, at most they want to see harm. And so you can screw somebody out of their entire life finances and get a really good night's sleep that night if you have antisocial personality disorder. And so that's really, I've heard something about like car lot salesmen. There's places that have sort of screened for these behavioral, where they can sort of say, yeah, this car is perfect, and really we've scaled back the odometer, and it's a piece of shit car in the last 2 weeks. So, but they can do that and go back and go to sleep, have a good
Feel
night's
all right
sleep.
about
Yep, and they feel okay
Because
about it.
they benefited.
Yeah, you benefited from it. Yeah.
Yeah, that is a good point though as well. The lack of empathy is
Yeah.
something that is throughout all of these.
Yeah.
The inability to see things from somebody else's
Right.
perspective
Yeah.
is classic through all of it.
To cluster B. Yeah,
Yeah.
I agree with that. If you have somebody with antisocial personality disorder, what are some approaches you can take as a nurse to deal with that person, or to, in any setting? I don't know. What do you think? What are your approaches?
It's difficult. Honestly, I think antisocial and narcissists are some of the most difficult.
Okay.
Because oftentimes you can't really get at the underlying issue.
Yeah.
Because it's so well guarded.
Yeah.
And they've got a lot of layers.
And if they don't care about the social consequences at all, then they really have no reason to want to get better.
Right. So honestly, if you are needing something from somebody who may have an antisocial disorder personality or a personality disorder, it just may end up being a barter session.
Okay.
And because sometimes, I mean, yeah, you don't want to play into stuff, but
Right.
if the ultimate outcome
Right.
is for the greater good of,
Yeah.
of them, or for if you're like thinking about your floor in the
Yeah.
milieu, it may just end up being a barter session in order to produce the greatest outcome
Yeah,
for
same
everybody involved. Otherwise, it takes a lot of therapy.
Yeah.
And first off, it also takes the person recognizing that this is
And
an
wanting
issue.
to change, yeah.
Right.
And
And
saying that, oh yeah, I
oftentimes-
see the consequences of my family, I see the consequence here, I want to do this, and usually if someone's hospitalized for a reason like this, they're at a severity that it's not gonna maybe not work. But also, I haven't seen anybody take an antisocial personality disorder focused therapy in any of these institutions.
because it's just such a difficult.
Yeah, it may not be worth it. So, with if you look at antisocial personality disorder as they absolutely the worst the most that they have something they want. A lot of times it's control. They really want that power, and at least you'll see somebody with some subtle antisocial personality disorders. Sometimes it's just they just don't want to be controlled. So I think there's sort of the scale of not wanting to be controlled or wanting to control. And at this up here, you have you can have as severe as people who hurt people and kidnap them or torture them, right? And they want that level of control. And over here, you can have somebody who just doesn't like rules and doesn't want to follow them.
Right.
So usually in these usually when you can really communicate the rules of the organization, and you can kind of say, if you follow these rules, then you get these outcomes.
Right. These benefits.
It takes a couple days maybe, but they usually figure it out.
Yep.
Or they'll play the game for a couple days, then they'll fight the system for a week, and then they'll play the game again.
Yeah. And that's the thing. Usually they'll play the game.
Yeah.
Because there are benefits.
There's incentives of playing the game. Yeah.
Right.
And there's some really severe cases of antisocial personality disorder where they've sort of mastered the game, and they like the game, and they like messing with people.
No, not messing with the game.
Yeah. So you'll see people start getting into fights, and then it won't really relate it to them, but they'll be like watching it, and you'll see them go and they'll whisper to somebody, and you'll say something like, "Hey, patient B's talking shit about you over there," and then you go over them and say, "Hey, patient A over there, he's been eyeballing you, hates you for this reason," and then they get in a fight, and they've sort of benefited from it. Yeah. I would say with identifiable antisocial personality disorder, you have a rule, you got to be really strict with it.
Mm-hmm.
And a lot of times you have to be really straightforward, and sometimes it can appear cold. Like hey, I want to go outside and smoke. You're on a med-surg floor, and you're like, that's the policy is you can't go outside and smoke. And then they'll fight it, but the more straightforward and consistent you can be, the less fighting you might have.
Right.
But I think there's a lot of room. It's a hard conundrum sometimes, because I think there really is room for bartering, because the goal is always the immediate safety.
Right.
So,
when that becomes
yeah.
right. So the greatest thing that any nurse is concerned about, especially on a psych floor, is the safety
Immediate
of
safety.
everybody.
Yeah, and I would come across at odds a lot of times with certain staff, because they would say, if you do this might encourage this behavior in the long run. And it's like, you're probably right, but my goal is the immediate safety.
Right. And the fact is that behavior's been encouraged for
Yeah,
your whole life.
we're not going to fix it.
Right. You're not going to fix that on
Not
the
right
psych
now.
floor
Yeah.
in a week.
In a week, we're not going to
It's
fix it.
gonna take
like
years.
It's going to take years
Take
of
a lot of
focus.
outpatient therapy.
Cool. So I wanted to bring that up because that's a easy testable thing. Sorry, go ahead.
I totally forgot what I was going to say.
Oh, sorry.
Oh, right. Border boundary setting is
Yeah.
very important for pretty much all of the cluster B.
Yeah.
So all four of those having those firm boundaries is very important.
Yeah, I absolutely agree. So let's do borderline. Borderline's kind of a fun one. It's kind of a weird one. I don't mean to be crass against it, but you really just get this huge variety of symptoms. And a lot of times what I notice and you can disagree with me if you want to, with people with borderline personality disorder, they often, especially if they're severe, they have these really interesting, warped, irreverent senses of humor. Like you can sort of appeal to the sense of humor sometimes, and you can get yourself out of a situation simply by even sometimes like in a way that you wouldn't think, making fun of the situation, and they'll sort of think it's funny, and then they'll like I've made somebody laugh. She's coming up to me and saying she's gonna do something horrible or whatever, and I ended up making her laugh, and she laughs, and then she walks away. It's like, oh, and then she's gonna come back for the next patient, the next staff who comes on next shift, and give them a hard time. But I had sort of won in this emotional game that they sometimes can play, and. But I don't know. What's your experience with borderline personality disorder, or maybe you can give a good definition of it? I don't know.
Well, the biggest driving seems to be the biggest driving thing for borderline is this sense of abandonment, whether it's real or whether it's perceived.
Yeah.
Like the example I tend to use is, you're walking, so you have a borderline and you're walking by them and you go, hi. And then you keep walking, and then they go, "Oh my gosh, that person is in love with me."
Okay. Yeah.
Right.
Yeah. Okay.
And then the next day, you're reading this paper, you're kind of going over some notes. They walk by and they say hi, and you just kind of look up and give them a nod, but then keep going. Then all of a sudden they're thinking, "Oh my God, they hate me.
Yes.
This is the worst day ever." And so
that's called splitting.
Right.
Yeah. Go ahead.
And so the labile aspect is basically just as oftentimes based off the real or perceived concept that somebody is abandoning them.
Yes.
And that causes this sort of.
And you also have that absolute thinking everything is good, everything is bad, and that's the splitting concept, and that's where that's a huge hallmark too. And then you have the perceived or actualized abandonment, which they're afraid of. And a lot of times you'll see in an interpersonal level, they're so afraid of this abandonment that they will facilitate it.
Right.
Like they'll have really intense, close relationships, right? Because of that same reason. You're nice to me, therefore we're gonna be the best friends ever. And then you start doing stuff like not picking up your phone right away, right? And you start doing stuff like, I don't know, looking at me weird, not texting me back after 5 minutes, or not texting me back after the 18th time I texted you, because it's such an intense emotional relationship that everything that's not perfect is perceived as bad. And so they'll start doing things because they'll think, oh, they don't like me anymore, they're going to abandon me. Right. So they'll start facilitating that happening, which I think is this defense mechanism that has probably worked for them in the past, that's kept them alive probably, or at least feeling safe. Like if I can facilitate this happening, then I'm in more control than if it happens, because they probably have experienced intense abandonment as probably a really young child. And in order to control that, they need to start feeling like they can control it when it was not controlled back then.
Well, and you bring up a good point with most, I think with probably all of these personality disorders, cluster A, B, and C, they're generally born out of an intense childhood that's had a lot of trauma and a lot of either abandonment, abuse, physical or sexual or emotional. Or just a very traumatic experience. And then these personalities are generally born out of that, out of an attempt to control and understand their environment.
Yes.
And
or survive their environment.
Right, just right.
Because you have, with borderline personality disorder, you'll have this dissociation, which probably was, because I think borderline personality disorder, I don't know the statistic off the top of my head, but I think it's 80% or probably more have experienced repeated sexual trauma. Right. And that's really a hallmark for borderline personality disorder. And so when it's childhood, so when you have a child who's experienced sexual trauma, which they're not designed to be able to experience, they will fragment, they'll disassociate, right? And then and so you'll have, and then also usually that also means you probably have co-occurring PTSD with every person who has borderline personality disorder. So they'll also have the PTSD lability, or you'll have the flashbacks and all of this will sort of play a role, and it can be very dysfunctional. But I think for somebody with borderline personality disorder, or somebody with extreme sexual trauma who may not have actual borderline personality disorder, understanding that these difficult personality traits really did keep them alive back then.
Right.
And they were essential for them to survive. Yeah. And they're very dysfunctional socially now, but they wouldn't be around if it wasn't because of them.
Right.
And so now the work is just to try to deal with that trauma and work with that behavior to try to improve their social standings. But people we tended to see in the hospital tended just to be really severe form of borderline personality. Yeah. Usually it was mixed with a little bit antisocial, so there's a decreased empathy. Sometimes they wanted to harm people, and or there's probably co-occurring substance abuse. So they're just a very challenging unit of this population, but definitely not representative of the whole population. So.
Yeah.
These people, this individual's nursing. What do you think nursing? What was your best approach with nursing? Good boundaries.
Boundaries.
Yeah.
Definitely a lot. Making sure you maintain boundaries, which
Yeah.
is really tough when you're talking about you've got like 10 or 11 staff, because
Yeah.
each staff member is going to
Yeah.
react to certain things differently.
For sure.
The other thing is to also make sure, because what will happen sometimes, borderlines are looking for some sort of reaction as well.
Yeah.
And so they may like cut on themselves, and
Right.
then they want you to go, oh my gosh,
Yeah.
what did you do?
Yeah.
But instead, if you go, oh, looks like you cut yourself, let's go ahead and fix
Yeah.
that up.
Normalize it.
Normalize
Minimize
it.
it. Work
And
with
then
it.
kind of think, and the other thing, just with self-interest behavior in the first place, is not to focus on the self-interest behavior, but to
What's
focus
causing
on
it, yeah.
the emotion
Yep.
that's going on with the self-interest behavior.
There's we had a student that I think we both worked with, and they told us a story about how they were doing vital signs in a person's room, and then they were saying, hey, do you guys need anything or want anything? And they had told the patient, do you need anything? And they said, no, I don't want to talk right now. I'm like, well, if you do want to talk, we're here. So the patient had used another staff to go summon this nursing student, came back, and then so the staff had summoned the nursing student, and then the patient went on to tell the nursing student about her suicidality, which we had just talked about it, so the student felt comfortable in at least discussing it with her, and then coming to the nurse right afterwards to and the nurse didn't mind necessarily. But there's some staff who really got after her, and I was even talked to about it later on, that she was counseling and the biggest thing was that they didn't want to feed into. Do you see my quotation marks? If we're just listening to this, I'm quotation marks. Feed into the patient's behavior because she benefited from that. So she would say things like, "I'm feeling suicidal," and so I think they maybe had good intentions, but they weren't doing anything real. They weren't really doing anything intentional other than thinking that they shouldn't feed into the behavior, which isn't really anything precise or exact, because there's a thing called extinction, which I think psychologists can do, but I don't think nurses can do extinction. No. Extinction is where you ignore the behavior completely,
right.
and then it'll go away after it has a burst, so it'll get worse and it'll get better. And if you are not familiar with extinction, then don't try it. And I don't know why they felt like they needed to try it. And the only approach I see that for nurses is, so you're seeing a behavior that's looking for attention, so how can you give her the attention that she needs,
the actual attention, right.
with the actual attention she needs, because she needs this attention, it's a human need, right? In a manner that encourages more positive or better coping behaviors.
Right.
And so a lot of times that means talking to her every half hour. That means if she does something good, praising her for it, right? Hey, I noticed that you got up in time for, the ADL supplies. It sounds like you're really, you're working on your schedule. And so giving her the attention for the things that are positive, and then not ignoring but minimizing or normalizing it. No, probably not normalizing, probably minimizing it when she does do it. But you can't ignore it.
Right.
That's how you get sued. I mean, that's not going to help her either.
Right. Well, and again, nurses are there for safety.
Safety, yes. Period.
Number one.
Right. If someone says they're suicidal, it doesn't matter why they're suicidal. It just matters that they said they're suicidal, and your intervention and your response is for safety. And if someone's suicidal, you absolutely cannot ignore that. That's there's nowhere in literature
Whether
to
they're
support
looking
that.
for attention or not.
Yeah.
That's honestly not for a nurse to determine.
That's not for a nurse to determine. Absolutely. So okay, cool. Histrionic and narcissistic. Have you seen those?
Oh yes.
You have seen them? Okay.
Yeah. Well, oftentimes I think histrionic gets confused with borderline often.
Yeah. What's the difference?
So histrionic. So borderline again. So the main driving force is that fear of abandonment.
Right. I hate you. Don't leave me.
Right.
No. Yeah. I hate you. Don't leave me. Yeah. Perfect.
Whereas histrionic is just attention seeking.
Yeah.
So whatever it takes to get your attention.
Yeah.
So oftentimes you'll see them being very somatic because illness.
So somatic meaning that they complain about physical illnesses,
right, yes,
but don't necessarily have them.
or they're not
maybe
as
they're exaggerating
intense.
them.
Yeah, they're exaggerating them. So
Yeah.
oh my elbow, oh my gosh, it's so bad, but you're like it's a small little cut.
Yeah, exactly.
So just very attentive. So they can be very, and oftentimes why you might not see them in the more intense like psych units.
Yeah.
Is because they're just looking for attention.
Yeah.
So they're
Not looking for negative attention necessarily.
No.
Yeah. Just any attention.
Just any attention. So oftentimes they can dress very promiscuously.
Yeah.
Because they're seeking attention from men
Mhm.
or from same
anybody.
sex or
Yeah.
whatever, or men dressing promiscuously. Oftentimes, histrionic and borderline tend to be more predominantly female, and then the narcissist and antisocial tend to be more male. Just to clarify that.
And actually, whenever I see somebody who's female with antisocial personality disorder, I honestly think it's mixed with borderline. And when I see men with borderline personality disorder as their diagnosis, it tends to look mixed with antisocial. I've seen people with borderline personality disorder, and that's what they have. That's perfect. It perfectly describes their disorder. That are usually women, but usually it's mixed with men. So I agree with that. That's what I've seen in it too.
Yeah. So histrionic just tends to be much more about.
Right. And it's not always necessarily unhealthy. But I mean, it has to. In order for it to be a disorder, it has to hurt your life in some way.
Right.
But it's never. It probably would require a therapist. Not, so you're not going to see them detained or hospitalized. They're probably not going to try to hurt themselves or others. They're probably still eating. So they're really,
So generally, when you do see a histrionic, it's because due to their sort of manipulative nature in trying to get that attention, they've pushed people away, and then oftentimes they become depressed about that, and then suicide.
You have co-occurring SI. Okay.
So that's oftentimes when you're going to see a
sense.
histrionic in the hospital is because of SI.
Right, and these disorders are really hard to have. And so to have co-occurring disorders is probably a majority of the cases. Yeah. So you're going to have something as well. And then narcissistic. How would you define narcissistic?
There probably was a bit of narcissistic people we'd see out at Easter, but where I work now at the VM, I see a bit more.
A bit more, yeah.
And so it's just a personality. So again, remember, it's built out of trauma. So generally speaking, a narcissist probably has one of the most fragile egos.
Okay.
Yet they've built up so many defenses about how awesome basically they are.
Yeah.
That helps defend that very fragile ego. Or eagle. I don't know. Maybe they've got an ego. No, the fragile ego they've got inside. So they've built up all these.
The eagle is so fragile. Look at him.
So every narcissist has a glass eagle.
Yeah. No, that's weird.
No, so there's just a lot of walls and defenses that they've set up. So oftentimes they have just a over-exaggerated sense of themselves. Over-exaggerated sense of their skills.
I gotcha. One guy was walking around telling, because we had Spanish speaking, so he was telling staff that, hey, if you need a translator, just let me know, and I can help translate for you. And this is he was. I don't know what it's just. I mean, probably is what it was. But he didn't know any Spanish. It was he would go up to them and be like, taco, enchilada, and he'd just say these random, sometimes not even Spanish, but just Latino sounding words, and then they would just have to smile at him, and he in his head could translate Spanish. Yeah. And it wasn't delusional. It was narcissism for sure. It was very weird.
Yeah, and that's the thing. It seems so odd because. Tends to be the more sort of narcissistic they are, the more it sort of borderlines on this delusional thought process that's going on, because they just have this overinflated sense of who they are. And you listen to their story and you go, okay, is this a psychotic?
Right, is this psychosis?
Because this is, there's no way.
This isn't true at all, but they may intellectually know it's not true, but but that's not, they're giving off that they can. Whereas psychosis, the delusion would be absolutely believed by the person.
Right.
And so they're telling you something they believe, and usually it's not organized, usually it's lacking a lot of those. Where somebody who's maybe narcissistic personality disorder is able to sort of adequately communicate their abilities to you, but they're really not realistic.
Right. And I think oftentimes they begin to believe
it.
Their own narcissistic thoughts, but and that's again, it's the ego doesn't want to be harmed, so they've actually even built upon, and that's usually when narcissists become really dangerous, is when you've actually pierced through to their ego.
Yeah. And then they're challenged it.
Right. And it's very difficult to pierce through all those defenses, but if you actually break all those defenses, you're probably going to have somebody who's actually can be very dangerous.
Because they lack the empathy too, or at least their importance is way more than other people's, and so they will absolutely harm to defend their fragile ego.
Yeah. And a good way to figure out if somebody is narcissist is if they're asking you who the best provider is, and that's the person they want to be with.
Oh yeah.
Because they only deserve the best.
Only deserve the best.
Right.
Yeah, I always say it's Jeremiah.
Wow.
Obviously. You want to talk to Jeremiah? He's over there.
And then there goes my narcissist.
Let's see. So cluster C, which is
Or the anxious.
anxious. Yeah. Okay. Anxiety-driven. Personality disorders. You have avoidant, dependent, and obsessive-compulsive personality disorder. I feel like avoidant and dependent kind of describe themselves. Is there any pearls in those? I haven't experienced them so much. But.
Not
It's
just
just
avoidant.
thinking of them as a pathology, right?
Right.
It's avoidant to the extent that it's harming their life and their interactions.
Right.
Dependent to the extent that it's harming themselves or somebody else.
Right. So any disorder is
Yeah.
basically I like the 3 L's.
Okay, let's hear it.
Live, love, and wait, no, what is it?
I was like, I want to put this on a test, so you gotta listen.
What is it? Live? Nah, I forgot. Oh, live, life, love.
Live, life,
Right.
love. Okay.
So living,
Yeah.
if it affects your job,
Yeah.
to the point where you're unable to maintain a job
Yeah.
and unable to maintain like
Right.
just the existence with having a house, with having
Yeah.
the things you need, food. So if you're affecting your living,
Yeah.
you're laughing, right? So just your ability to enjoy life.
Right.
If it is to the point where it's affecting that, or if it's affecting love, so if it's affecting your relationships with people,
Yeah.
not just somebody that, not necessarily just a significant other,
Right.
but family, friends. If it's to the point where it is severely detrimental to any of those 3 areas,
Yeah.
then it starts to become a
A
disorder.
disorder of some kind. Because I go through each one of these and it's like, oh, I know one of these. Oh, I know one of these.
Right.
Right. But it's not. They're not. And honestly, someone could look at this and say, Nick, you do this and you do this. We all have pieces of this because these are all developed from developmental sort of poor coping or developmental, sort of missteps which we've all taken.
Mm-hmm.
So we all have pieces of these, or all of us have some pieces of these. But they're keeping a job. They have good relationships. They have people in their life. Sure, maybe their quality of life would improve, but they do not have a disorder, and we would not want to stigmatize them with something like this. If we were to tell somebody they have dependent personality disorder, it's because it is the reason why it is inhibiting their life, and we want to make that the focus of our treatment in order to help them, right? Which isn't necessarily the role of the nurse. The nurse can identify these, but, and you can think about, well, how can I, someone who's dependent personality disorder. I remember we had a patient who she wouldn't dump the food into the garbage. She'd put it on the garbage, or she'd stand there and ask for help. So the first couple of weeks, we just did it for her because whatever. But then we realized she wouldn't do these things. She wouldn't drain the bathtub. It was very weird. She wouldn't do it. Yeah. And so you drain it, but you realize how debilitating that is. And so we started doing things like we would have a 1-to-1 who would sit with her with the tray in her hand for just an hour, and we wouldn't leave until she dumped it, right? Or we would.
Oh, that's right.
Do you remember what I'm talking about?
Yeah.
That was very challenging. She was very debilitated, but I think she had a couple other co-occurring illnesses too. Yeah, but that's when you can't function in life like that. You can't go to the store and buy milk, right, and have that debilitating of dependency.
And what's interesting is oftentimes they're dependent on other people.
Yeah.
And that very thing is what drives those other people. They're so afraid of other people leaving.
Yeah.
That's actually
Right.
what ends up driving them away is sort of
Right.
their over-dependence.
But it's an attempt to keep them around.
But it's right.
But
It's
probably
an attempt.
because, like we said, a childhood event or events where they needed, it worked to keep somebody around
Right.
when they're probably experiencing a lot of abandonment.
But then when you're talking about a 25,
Yeah.
30-year-old who's doing
It's just
it,
not working.
it becomes no
Yeah.
longer
Yeah.
doable.
Yeah, it's just it's hurting that. And then obsessive compulsive personality disorder. How do we differentiate that between OCD, which is obsessive compulsive disorder?
Right. So one's personality, one's not.
Yeah.
Right. And one is where somebody. So the whole idea, like when you're talking about, like, so somebody has to tap their knee 15 times before they can get up and walk out of the room. That's OCD.
Yeah.
Right. So or they're just washing their hands.
Yeah.
They can't stop washing their hands, and they have to wash their hands for 15 minutes and scalding hot water. That's OCD. So obsessive compulsive personality disorder is more everything. It's a lot of just about control.
Yeah. Okay.
Where OCD is about it's somewhat about control. But
Yeah. They have the obsessions, which is like probably if they're washing their hands is about cleanliness, and then the compulsions, which help relieve the anxiety of the obsessions.
Right.
Sometimes they can be related, like if everything's dirty, I have to wash my hands. Sometimes they can be unrelated. and the tapping of the knee to leave is probably not related to their obsession, but it's required in order for them to relieve enough anxiety for them to function.
Right. It's about relieving the anxiety.
Yeah.
Whereas this is about just control,
Yeah.
controlling their environment, controlling the people who are around them.
Yeah.
And again, they tend to push people away.
Uh-huh.
Just even though that what they're trying to do
Yeah.
is keep people close, and
Right.
or they're oftentimes very harsh on themselves as well, because
Okay.
they've got these sort of rules and regulations and these well-defined borders of what somebody
Yeah.
should be like, or what they
Yeah.
need to do, or what they shouldn't be doing, what they
Yeah.
should, and nobody can.
And they can't even live up to it
Right.
themselves.
They can't live it up to
And
themselves.
so it affects them emotionally from that.
Yeah.
Yeah.
And oftentimes, you're right, it affects them.
Yeah.
Such a debilitating, another just debilitating
Yeah.
disorder, because just living with that sort of anxiety and just almost self-loathing and self-hate for yourself
Yeah.
just all the time.
Yeah.
Gosh.
Yeah. Have you felt like you've experienced that? Have you seen anybody with that?
You know, I haven't seen. I don't know if I've seen that one. I've seen the avoidant and dependent.
Yeah.
Um,
I've seen the independent.
and honestly, I work inpatient, so I don't know if the obsessive compulsive personality disorder. You may just view it as more just as a OC, just general OCD.
Yeah, it probably gets
difficult to
categorized
sometimes-
and it's not the priority of their admission. And
Right.
so it exists, but we don't really. I can think of a patient that we had, I think this last quarter, it was in the first quarter, so it's in the nursing home, and she would want a cup to be placed on the counter in a very specific way. And the students were very successful with her when they gave her a good amount of time. The staff who couldn't or wouldn't give them time ended up spending more time with her because it was sort of this battle for time. Whereas and I think that was you sort of meeting, why is she doing it this way? And so thinking about it and the meeting that need proactively instead of retroactively, where you're like, okay, so they're being very precise, which means she probably is, she wants you to do it in a precise way because she needs that level of interaction. And so letting her have that, can get her through the day smoother. It was definitely in control, definitely a perfectionistic kind of approach, rather than with the obsessives and the compulsives. So that's not a common one that you see. I don't know what the statistics are on that one, but.
Well, and oftentimes it's just going to look like a very type A personality.
Yeah, very type A. Yeah.
Like an ultra type A.
Yeah.
So oftentimes they can be very functional in life.
Yeah.
Because
Oh yeah.
they get things done.
Yeah. Maybe you can
Because
even
they-
add to it, like they can they do things so well, maybe it's perfectly, or expect, this level of perfection that they're it's valued maybe. I remember I was watching Monk, and he was reading a magazine and he identified 100 errors or something like it was a ready to print magazine, and he went through it, and then they offered him a job.
Right.
He was afraid they weren't because he was too but they needed that level of hyper focused perfection for the magazine. That was kind of, I guess, random off now. I don't know. What do you think? Any other thoughts about personality disorders or therapeutic communication that we talked about? Any closing?
Yeah, the one thing I would just say, personality disorders are difficult.
Yeah.
When you're talking about psychosis or bipolar or
Mhm.
depression or anxieties just in
Yeah.
general, we have a lot of meds.
Yeah.
We have a lot of ways to fix
Yeah.
in the next month, sometimes longer, these issues. With personality disorders, it is an ingrained system.
Yeah.
And
Deep seated for sure.
there isn't, if you're an inpatient nurse,
Working in
on
an inpatient unit.
right, on an inpatient unit, you're not going to fix it.
Yeah.
You're not going to fix it in the time that you have.
Right.
Outpatient, you may see change
Right.
as a nurse, because it takes years
Yeah.
to work on personality disorders, and years to undo just years of
Yeah.
trauma and poor coping that they have learned in order
Yeah.
to deal with that trauma. So that's why I think sometimes, especially the cluster Bs that tend to actually cause problems, like on the
Yeah.
floor, people get really frustrated and upset, and just, why isn't this changing? But it's because it takes
Yeah.
it takes years
Yeah.
to deal with these and to help fix these.
And the nursing focus should always be the immediate safety.
Right.
And keep in mind, even with all of this, deep-seated, so these behaviors are from, all these things that happened in the past. Still, when they do something, there's a reason why somebody does that, right? There's a need they're trying to fill, and if it's really an unhealthy thing to do, think of it. Try to think of it ahead of the. Think of, well, why is she really focused on where the cup goes, or
Right.
why is this person saying they're going to hurt themselves when it seems to be out of attention? Think about what need they're trying to meet, and in your nursing treatment plan can be focused on meeting that need. And it's like, well, that seems like a lot. It's like, it might be a lot, but the truth is you're going to be able to, they're going to be happier, you're going to be more effective, you're probably going to save some time if you can get ahead of it and meet those needs before, right? And a lot of times it's just checking in on people
Right.
and just saying, what do you need? What's going on?
One of the favorite things that I remember from Eastern is one of the nurses saying, I find out who my borderlines are and I check in with them at the start of the day.
Yeah.
Every day.
Every day.
Because that saves me
Yep.
from having to deal with a blow up
Yeah. Because
3 or 4 hours later.
Yep.
That takes even more time. And so don't just do it because of time management.
Right. That's why I'm trying to avoid that.
But
But it's better for them.
it's better for the patient.
It's they're gonna have a happier day. They're gonna feel better about themselves.
You're gonna feel connected.
Yeah, absolutely. Cool, man.
All right.
I'm not gonna touch that.
Thanks.
I'm gonna let Ben touch that.